Okay, we opened the door for more autoimmune diseases which are systemic in their nature rather than just primarily localized. And rheumatoid arthritis is the second mother of all classic systemic autoimmune diseases. And you should never ever think of it as being localized, even though primarily and most severely clinically it's expressed in joints. Rheumatoid arthritis is a systemic autoimmune disease in which many lesions are present, not only in the joints but in internal organs, lung, skin, many other places. Similarly, if you want to think of Sjogren's syndrome as primarily a localized form of inflammation of the salivary glands, you can, but it's also a systemic autoimmune diseases related to problems in many other places. Scleroderma, if you'd like to think of that as limited to the skin, you're just downright wrong. The fibrosis of chronic scleroderma extends to all connective tissues, and that's why it's no longer called scleroderma. That's why it's called systemic sclerosis. In rheumatoid arthritis, we could see some ulnar deviation at the MP joints here, which is classical, and we'll get into the more specifics of the disease when we get into the chapter on bone and joints. If you look at the bottom here, this is a normal synovium. It's just a couple of cells thick, the synovial cells, macrophage-like cells, perhaps a little bit of connective tissue, very thin, very shiny synovial cells. Well, look at them over here in the northeast. Look at the massive infiltrates of inflammatory cells involving these synovial membranes. This is a whopping, severe, often acute synovitis, which is the primary histopathologic process in rheumatoid arthritis. In Sjogren's syndrome, often we have enlargement and inflammation of the various salivary glands. In this case, from the location, you can see it's parotid, but it's a systemic disease as well. If you could recognize this piece of tissue as representing salivary gland, you know it's probably not parotid because you could see some mucus acini like here and here and here, and there's a lot of them. This is totally mixed, so you know it's more likely submandibular gland. This is normal. You could see ducts in the lobules, outside the lobules, a lot of fat. This is classical severe sialadenitis with Sjogren's syndrome. You see total disruption and destruction of the acini and ducts and heavy infiltrates of chiefly lymphocytes. And here you can see some remnants of some of the larger ducts and persistence of a little bit of fat as well. Let's talk about scleroderma. If you would recognize this as being relatively normal skin, you can see a variety of skin appendages here extending into the dermis. You could see relatively good differentiation between papillary dermis and reticular dermis. Well, in scleroderma, this is all fibrotic. You have loss of skin appendages. You have more dense fibrosis and less of a differentiation between the more delicate papillary dermis and the denser reticular dermis. Here you can see some fibrosis and chronic inflammation in some of the sweat glands underneath the skin. It may result as a skin picture looking very much like this. This is a severe case, but don't forget this is a systemic disease. So the same fibrosis that we see going on in the dermis could very easily and will be going on in internal organs as well, such as esophagus, gastrointestinal tract, pleural, peritoneal surfaces. This is a systemic sclerosis. If you would like to look primarily, once again, at the local autoimmune diseases, in every case, you have to recognize that there are local antigens which are being attacked by the immune process. And in the case of thyroiditis, we're talking about antibodies against microsomes of thyroid cells or thyroglobulin. So if your patient has Hashimoto's, you're suspecting that it's patient comes in with hypothyroidism, you're suspecting the number one cause, you order antibodies against microsomal and thyroglobulin autoantibodies. Autoimmune hemolytic anemia, cells being destroyed by virtue of antibodies attacking antigens on red cell surfaces. Multiple sclerosis, whereas still very much a mysterious disease, I think generally regarded as being autoimmune, autoimmune orchitis. Actually, any disease which starts out with the name autoimmune will then give you the name of the tissue or organ or cell which is being attacked. In Goodpasture syndrome, you have to remember it's the glomerular basement membrane as well as lung antigens. And here it's platelets. And here it's pernicious anemia. It's the antibodies against intrinsic factor produced in the gastric mucosa. In insulin-dependent diabetes mellitus or type 1 or juvenile, it's against the patient's own beta cells in the islets, so you would get an autoimmune ileitis, isletitis, if you will. In myasthenia gravis, it's antibodies against the interface between nerves and muscles, the neuromuscular junction. In Graves' disease, once again, it's antibodies against some thyroid elements. But isn't it interesting that the same disease process, autoimmune, that causes a hypothyroidism can also cause a hyperthyroidism? And we'll move on to the next category, the immunodeficiencies, in the next group. And I thank you very much.